Yeah, thank you very much. Good morning, everybody. I really want to thank the organizers for inviting me to come here. I said to somebody earlier today that everyone who has been here will take something home, something that you understand, something that an action that you want to do. I thank them for the topics, very down to heart and very practical things that both physicians and the community will find very useful. So thank you so much. So I'm supposed to be speaking on, does U equals U apply to breastfeeding? And I'll talk on the background of U equals U, evidence for breastfeeding in HIV, the similarities between the relationship of sexual partners and mothers who have breastfeeding or who wants to breastfeed, and then U equals U in breastfeeding. What is the evidence that we have so far, and what are the gaps? And then I'll conclude. Undetectable equals untransmittable campaign was launched in the year 2016. And this changed the HIV prevention message, okay, that is given to the serodifferent partners. The message is simple, that if you are HIV positive and you are on continuous antiretroviral therapy and you are virologically suppressed, you cannot transmit the virus sexually. That's a simple message. And we had somebody tell us that yesterday. He said for 10 years, he's had a serodifferent partner, and they've had open sex, and it's not infected. So the U equals U for sexual transmission has been very successful and impactful. It has actually galvanized public support for ART. The donors were getting tired of providing free drugs. But this made them know that, okay, there's a future, there's an end to this thing. And so there's more interest in providing antiviral drugs for the community. It has also led to the increased number of people living with HIV/AIDS who are now on lifelong antiretroviral therapy. Initially, there was no hope. It's like, how long will I continue this? You know, what is the essence of it? But when people know that there's something, you can still live a normal life like others, then that's removed the barrier that was created by this discontent. There were lots of scientific evidence that showed that indeed U equals U in sexual transmission. The HPTN 052 clinical trial that was conducted in the US had serodiscordant couples, and only one transmission occurred in those couples. And in this case, because it was in the early weeks of the ART that the person commenced ART, before the viral suppression was achieved, that's when the transmission occurred. And then we have the partner studies, partner 1 and partner 2 studies. And they had about 800 couples who were not using condoms. And 1/3 of them who were gay couples had STIs. And yet, none of them had the virus transmitted to the other partner. The same thing happened in the partner 2 study. In this case, after 77 sexual exposures, there was a 0 transmission. You know, this patient, the infected partners were on ART. That we must say, and adherence was also one of the things that was looked into. So breastfeeding in the context of HIV, at the beginning of the epidemic, there was so much about breastfeeding and HIV. And so after so many steps, we ended up with the recommendations for low-income versus high-income countries. The low-income countries, WHO, the World Health Organization in 2016, had a recommendation for lifelong ART, the option B+. Whereas the high-income countries, they had different guidelines for each of the countries. And until last year, when U equals U, brought a slight change even to their recommendation. So the low-income countries, WHO recommendation, which I'm sure we are familiar with, okay, that's the guideline by the side. So it talks about the duration of breastfeeding by mothers living with HIV. And mothers living with HIV should breastfeed for at least 12 months. And they may continue breastfeeding for up to 24 months or longer. This is very low evidence, of course, but while being fully supported for ALT adherence, that was a strong recommendation by the World Health Organization for the low and middle income countries. The basis for the WHO recommendation was that this is a 2024 publication that shows that infections is the highest cause of mortality in under 5 in developing countries. And also, studies that was published earlier in Lancet also showed that breastfeeding can reduce 13% of mortality due to infections. And that means that's the best intervention. You can see that it has 13%, others were 2%, 5%. Okay, so breastfeeding is a key cornerstone. The cause of death is infections. And the study that was done afterwards, this study, the MASHI study in Botswana, showed that early infant mortality is higher among those who had formula feeds than those who had breast milk. And usually, in the first 6 months of life, when you introduce formula feeds, that's when the mortality tends to occur. And the infections were also responsible for this mortality. Pneumonia and diarrhea diseases were the main causes of death. And this was the reason why WHO felt in terms of harm and benefits, breastfeeding was the best to introduce, to be recommended for developing countries. And so replacement feeding is not always associated with better HIV-free survival. Okay, the child may not survive. The child may not have HIV, but may also not survive. And we wanted HIV-free survival. So breastfeeding seems to be the cornerstone for that. And this is a summary of selected high-income country guidelines, as a WHO guideline on breastfeeding. In the UK, the British HIV Association in 2020 recommended formula feeding and always said informed decision to breastfeed should be supported if biologically suppressed and the mother is on ALT with good maternal adherence. Whereas in the US, formula or banked pasteurized donor human milk feeding was recommended. In Switzerland, breastfeeding should not be actively recommended. That was the recommendation that was made. And compared to WHO, which said supports breastfeeding for all. And the duration differed. So the rates, unfortunately, of recent, there has been an increased desire in high-income countries by mothers to also breastfeed their children. In Germany, after surveying 15 facilities, they found out that in the year 2009, only one mother wanted to breastfeed, whereas in the year 2020, 13 mothers who were HIV infected wanted to breastfeed. Similarly, in the United States, about 93 HIV clinicians were surveyed, and 1/3 of them said their clients still breastfed even after clear instructions not to do so. And studies from high-income countries have reported that acute and permanent grief, feelings of loss, and ongoing sadness were seen among mothers who were living with HIV, okay, because they were not allowed to breastfeed their babies. And the references are there. And it's been said that maybe there has been some migration from Asia and African countries to high-income countries. And some of these women are HIV infected, and they've nursed a baby in their country by breastfeeding the child. And the child is HIV negative. So now they want to have another baby, and they're in the country which says, do not breastfeed. So there's some control, there's some conflict in their mind on this. You know, they want to do it, and you are saying, don't do it. Okay, so this actually has something to do with your human rights and the body autonomy. You know, you want to do something, you want to marry somebody, but because the person is HIV infected, you are not allowed to. Or because you're HIV infected, the person is HIV negative, you don't have the right. The same thing with breastfeeding. The mother is HIV infected, and she, in the culture where she comes from, breastfeed, that's the norm. but she's not allowed to because of recommendation. It's a form of discrimination and stigmatization. Actually, it's also widening the gap in equity, health equity between the infected and non-infected persons. And it affects the bonding that will have occurred between the mother and the child if she breastfeeds, and also between sexual partners. So there are some similarities between U equals U in sexual transmission and in breastfeeding. So the question then arises now, can we extend this to breastfeeding? Do we have enough evidence? Do you have enough evidence to say, yes, U equals U in breastfeeding? So we have the Keshobora study that was done some years back, and this was published in the year 2011. Okay, where there are two groups. One group was on combination antiretroviral therapy, and they were widowed at 26 weeks. The other group was on AZT and single dose nevirapine. And the first group, at 12 months, the transmission rate was 5 to 4%. Compared to 9 to 5%. So combination antiretroviral therapy in this study was very beneficial and reduced transmission. Remember that this was at the beginning when we didn't know too many things, okay? Adherence and the rest did not come in. And some of these mothers may not have been on the drug for long enough to have enough suppression. Okay, and the Mabana trial in Botswana too. This was maternal third trimester ALT. About 560 mothers were randomized, and they were in two arms. They had combination antiretroviral therapy, and then the control arm also had antiretroviral, had antenatal zidovudine, lamivudine with nevirapine, only antenatal. But it was found that 1.1% was the transmission rate across the three studies, the three arms. So using antiretroviral drugs actually reduced transmission drastically. At least this was what this study showed. The BAN trial, where they had over 2,000 enrollments, had three arms as well. The control arm had 1 week of neonatal ARV prophylaxis, whereas the infant ARV prophylaxis was in one arm, and then the maternal ARV was also given to the second arm. And in this, you notice that the control arm that had only neonatal ARV prophylaxis had about 5.7 transmission rate, higher than the others. So maternal antiretroviral drugs and also infant ARV were better than not to have any ARV. The higher transmission occurred in the control arm. And the HPTN-046 trial also shows that in 4 African countries, the HIV transmission rates were 1.1% in those who had extended treatment arm. They had the drug for 6 months or while the child was breastfeeding, compared to those who had it for only 6 weeks. So the longer the child had the drugs, the better the outcome, the less the transmission rate. And the PROMISE trial, the popular PROMISE trial, this shows that the infant HIV infection was 0.5% in the maternal ALT and 0.5% also in the infant nevirapine. So you can see that the studies are not consistent. Some shows that maternal ALT, combined maternal, was better than infant. Some show that the infant ALT was better, and some is saying that the two of them, there's no difference, okay? So, and then the systematic review of 2016 shows that ART was mostly provided for only PMTCT then. And so we had 1% transmission at 6 months and 2.9% at 12 months. And it had been said that at this time, because it was only meant for prevention of mother-to-child transmission, it wasn't a continuous live thing. So we are not sure that the mothers were properly suppressed. You know, so that is not enough evidence to help us. So there is insufficient evidence for me. I think involvement of both cell-associated DNA also complicates breastfeeding transmission, because in sexual transmission, it's mainly cell-free RNA. But in the HIV, in the breast milk, we also have cell-associated DNA. We even have some latent cells, and some cells which are right in the breast milk itself, macrophages and some dendritic cells. And these cells are right inside the tissues, and they can be there for 44 months. And the common ALT that we use now do not penetrate into these tissues at this time. So with this, we have to unravel the role of breast milk cells in HIV transmission. we need further studies to know whether ART combinations affect resistance in the infants, because they are going to be about 10% of the drug that the mother takes will get to the baby. That's not adequate to treat for a child who becomes infected. And also, what is the side effects of this ARV on the babies? These are yet to be studied. Moreover, adherence is the key if you're going to talk of U equals U. And we know that postpartum, most mothers have a lot of difficulties, either mentally or also socially, and they may not be able to maintain the undetected level. That has been shown in so many studies. Okay, so the infant prophylaxis, what do we use? What is the best drug to use? What is the best drug to use? Okay, and then the monitoring. When do we do monitor? There's so many guidelines now. Should we monitor such mothers for the viral load every month or twice a month like it's done in the US? Or what do you do? Okay, so these are the gaps in evidence and research priorities. And there are so many studies going on to inflect to behavioral changes in terms of maybe sending M-Health, sending text to the mothers so that they can remember to take their drugs so that the viral load can be undetectable, and also therapeutic drug monitoring in plasma of mother and child and breast milk. So as we close the gap, I want to say that access to routine viral load testing is still limited in most low and middle income countries. And in fact, sometimes we have ART stockouts, we still have that. And supportive laboratory tests, sometimes they are borne even by the patients themselves. So in conclusion, I would want to end up that say that breastfeeding, U equals U, is still possible in breastfeeding. I believe it because we have done it in developing countries. For so many years, many mothers have been breastfeeding. And in my center, not one of them have had HIV transmitted to their babies as long as they take their drugs from the beginning. And so I believe, like Doreen said yesterday, U equals U should be business of everyone. Thank you very much.